Asked me to talk about atrial fib. I've given this lecture actually to the surgical residents and given it to the internal medicine residents. So you guys are getting the same knowledge as they're getting. But you guys are probably better at actually applying some of that stuff sometimes and making decisions. So maybe this will help everybody. So we're going to go over the epidemiology and background, anticoagulation and bleeding risk, rate versus rhythm control, and then ways to achieve rate and rhythm control, and then when do we call in for a catheter ablation on these things. So the incidence and prevalence of atrial fib, it affects approximately 2.2 million Americans. It's strongly age dependent. Affecting 4% of individuals older than 60 years and 8% older than 80 years. So approximately 25% of individuals aged 40 years and older will develop atrial fib during their lifetime. The prevalence of atrial fib is 0.1% in patients younger than 55 years, 3.8% in persons 60 years or older, and 10% in persons 80 years or older. So obviously, you see a lot of patients who are getting up there in age, and atrial fib is very common. I sometimes think probably one of the top reasons we get consulted is for atrial fib. So, and that goes along with the age. In 10 to 15% of cases of atrial fib, the disease occurs in the absence of comorbidities, lone atrial fib. However, atrial fib is also associated with other diseases, cardiovascular diseases, hypertension, heart failure, diabetic-related heart disease, ischemic heart disease, valvular, dilated, hypertrophic, restrictive, and congenital cardiomyopathy. So basically, anything that deals with the heart, it can set you into atrial fib. AFib is associated with a 1.5 to 1.9-fold higher risk of death, which is in part due to the strong association between atrial fib and thromboembolic events, according to data from the Framingham study. So we'll go over the kind of the two major things of atrial fib management, which is anticoagulation, and then rate and rhythm control, which is really the hallmarks of those. So classifications of atrial fib, depending on where you work, surgical versus medical. You'll see a lot of paroxysmal atrial fib, which is episodes of atrial fib that terminate spontaneously within 7 days, and most episodes last less than 24 hours. There is persistent atrial fib. These ones last for more than 7 days and may require either pharmacologic or electrical intervention to terminate. And then permanent atrial fib, and this is atrial fib that has persisted for more than a year, either because cardioversion has failed or because cardioversion has not been attempted. The classification schema pertains to cases that are not related to reversible causes of atrial fib. This is like thyrotoxicosis, electrolyte abnormalities, alcohol intoxication, also atrial fib due to acute MI, cardiac surgery, pericarditis, pulmonary embolism, or acute pulmonary disease is considered separately because in these situations, AFib is less likely to recur once the precipitating condition has been treated adequately and has resolved. So even post-op, you see a lot of atrial fibrillation. And if you can treat the underlying cause, then you're not in the same boat as if somebody comes in with atrial fib on their own. So again, we have to look for reversible causes, which would be thyrotoxicosis. We get thyroid studies, and then try to treat the underlying condition. The other one that I see a lot is sepsis. You see a lot of people when their catecholamines are all revved up, and it's causing rapid rate. Prognosis and stroke risk. Atrial fib is associated with increased morbidity and mortality, in part due to the risk of thromboembolic disease, particularly stroke in atrial fib, and in part due to its associated risk factors. Again, it is associated with a 1.5 to 1.9-fold higher risk of death, which is due to thromboembolism and atrial fib. So who's at risk for thromboembolic events? This is one score that basically everybody uses. It's the CHADS2 score. And basically, this will tell you the risk of having a stroke or a thromboembolic event. So CHADS is a, what is that, a mnemonic for CHF, hypertension, age greater than 75 years, diabetes, and stroke. And then the 2 is that you get 2 points for having a prior stroke or TIA. And then this is the categories. Low risk is 0, 1.2 to 3 strokes per 100 patient years, 1 to 2, which is moderate risk, and then greater than 3 is considered high risk. So this is what we use to kind of determine whether we're going to put someone on Coumadin or aspirin. So, and this kind of applies to everybody. So you really do need to, you know, this is kind of going with quantification rather than kind of like, well, they're kind of old and maybe they do have a stroke. I mean, this is actually being pushed out a lot more now. So the 2006 ACC/AHA guidelines said that if you had a CHADS2 score of 0, it'd be aspirin 81 to 325. If you have one risk factor, you could do aspirin or warfarin with a target INR of 2.5, which would be 2 to 3. CHADS2 greater than 2 or mitral stenosis, you need a target INR of 2.0, and then a prosthetic valve, AFib, you would go 2.5 to 3.5. So this is the latest iteration of the CHADS score. This is gives you a little bit more sensitivity. It's called CHADS2 VASC, and basically it's the CHADS score with vascular disease, which includes MI and peripheral vascular disease, age 65 to 74, so now if you're greater than 75, you get 2 points. And sex category female, which means 1 more point. So this is the VASC part of this. So if you hear the VASC part of this, this can increase the sensitivity of you're looking for somebody who needs to be on anticoagulation. So basically, you know, if we did the score on everybody, almost everybody would be on Coumadin. So there becomes a, you know, so there is also kind of an art of medicine as much as there is like a, you know, science of medicine. So I see this as kind of the science. You're kind of like, oh, well, they've got a CHADS2 score of 3, but they're like 80 and, you know, she's falling a lot. And, you know, you're kind of like, well, I want to do something, but maybe not give her the full anticoagulation. This is when you do the CHADS2 VASC score, what's the incidence of stroke? So as you get up there, it's, you know, 1, you get 1%, 2, 2%, 3, and then 4, and then as you get up to 5, 6, 7, 8, 9, obviously it gets a lot higher, so 7 to 15% with CHADS2 greater than 5. These are the 2010 European guidelines, and what they basically say is if you have a CHADS2 score greater than 2, you use, do you guys have a pointer or no? You don't have a laser pointer.
Laser pointer.
You do?
Mm-hmm.
Oh, great.
I'll have to get it out. Whoops, oh, it's over here.
So, so your CHADS2 score, if it's greater than 2, you go to oral anticoagulation, and that means Coumadin, and we'll go over some of those new agents too.
Plug it into the laptop, but there's your pointer. One on the bottom, and
Oh, this is it. That's all I need.
well, okay.
It should be fine.
There.
Oh, yeah.
Okay.
So CHADS2 greater than 2, you get oral anticoagulation. Age greater than 75, that's already a 2, so then you end up with oral anticoagulation. 2 other risk factors, again, oral anticoagulation. Then if you only have 1 other risk factor, you can use either oral anticoagulation. Then if you don't have any, you can use aspirin. But again, this is based off that CHADS2 VASC score. So, you know, that CHADS2 score is for people who is trying to estimate risk on people who have a risk of thromboembolism or you know, a stroke risk, or you know, throwing a clot. This is actually your bleeding risk. So if you were to, so this helps you to quantify kind of, okay, instead of saying, okay, yeah, it's the 80-year-old who falls a lot, you know, this is going to tell you, okay, well, what, you know, try to give you some type of estimate of what the risk of bleeding is. So if they have hypertension greater than 160, that's a 1. Abnormal hepatic, or renal or hepatic function, that's a 1 for renal, and then 2 for hepatic. Stroke is 1. Bleeding history or anemia is 1. So like history of a GI bleed or something like that. Labile INR. Elderly, age greater than 75. Drugs and alcohol with antiplatelet and NSAIDs, 1 or 2. So alcohol is a 2. Drugs, depending on the drugs, it's 1. So high risk is greater than 4%. Moderate risk is 2 to 3, which is 2 to 4%, and low risk is less than 2. So that you could use this in conjunction with the CHADS2 score, and what you got is basically now a way of saying, okay, well, they would need Coumadin, but then you know they're at a high risk for bleeding. So somebody who's had, say, like a GI bleed, a stroke, and hypertension, you know, now you're saying, okay, well, they got probably a 3% chance of having a fatal bleed. So we don't do that. So when you're talking about anticoagulants, oral anticoagulation, right? So we've got aspirin, 81 or 325. We've got Coumadin, which is, you know, usually you have to heparinize people to get them on Coumadin. And then these new agents, which is dabigatran, which is Pradaxa, rivaroxaban, which is Xarelto, and apixaban, which is Eliquis. So I'll kind of, let me go through some of that stuff. So from a practical point of view, and I just actually spoke with Subkata about this the other day, there's a lot of controversy over 81 and 325 of aspirin as far as, in the coronary literature, there's nothing that actually supports using a 325 greater than using just a baby aspirin. Okay, so that's in coronary stuff. In stroke literature, though, there has been a difference between 81 and 325. So that sometimes also comes into play. Mayo Clinic, they recommend basically using 2 baby aspirin. So that's why you see a lot of people using 162, or at least me who use 162. And the reason is that the American studies all used 81. The European studies used 100. So if by going strictly by the data, you have to use 2 baby aspirin. So that's kind of a way to split the middle. If I really think someone's at a higher risk of stroke, I will give them the 325. Another question is enteric-coated versus non-enteric-coated. There's been some problems with aspirin resistance and things like that, and they think that it's due to the enteric coating, but I don't know that I've seen that to be true. So, I mean, I use enteric-coated aspirin just because I'm trying to avoid a GI bleed on these people. So, Coumadin, let me talk to you guys about that. You see a lot of different practices with people bridging and not bridging. For atrial fib, you do not need to bridge. Okay, they can just, I mean, pretend that they're an outpatient. They come in with atrial fib, and you can just put them on Coumadin, 5 milligrams, and go ahead and you know, let them drift up and get their thing. The theoretical risk of starting Coumadin without bridging is the protein C and protein S deficiency, which can then cause hypercoagulability. The thing was that when that was occurring was when people were loading Coumadin, like 10, 15, 20 milligrams at a time, you know, without any other bridging. So that's when that was occurring. So as long as you kind of stay right at 5, I think you're okay with that. You do need to bridge, however, when you have a valvular problem and when you have like a DVT or a PE. Okay, so those definitely, and whenever you have a clot or anything, you do need to bridge. Okay, so back to the new agents. So Pradaxa. Pradaxa was the first one to come out onto the market of the new oral anticoagulants. This was actually the, I believe it was the RELY trial, and this actually showed superiority to Coumadin. So all of these drugs actually have shown superiority to Coumadin, which is a really good thing. Okay, not only that, but all of these drugs, there's no INR check. You don't have to stay away from greens. The only knock on them right now is that you cannot reverse them, okay? Now, I don't know if you guys, in your limited experience, as far as what do you guys think about reversing Coumadin? Does it work? Does it, you know? I don't see that it actually works very often. So if you're going to have a life-threatening GI or bleed from Coumadin, you're either going to die or you're not. I mean, you're going to get the same stuff. You're going to get reversed with, you're going to get blood, you're going to get platelets, you're going to get FFP, you're going to get all of it, right? So in a way, it's kind of like the cat's out of the horse is out of the barn at that point. So it's kind of like, I don't really know that, it makes some people feel better that there's, quote, a reversal agent for it, but I don't really see that that's the case. The truth is the half-life of these things are actually a lot shorter than Coumadin. So that actually makes this, I mean, and actually from a bleeding perspective, Eliquis was actually shown to be better than Coumadin. So not only was it more efficacious, it actually had less bleeding. So Eliquis is the, I believe that's the Aristotle trial, and then this is the, I'm trying to remember which one this was. This was Rocket AF. So I like Xarelto. Xarelto is once-a-day dosing. I seem to think that that's probably better for compliance. Pradaxa has been getting a lot of, they get a lot of heat on them because of, they were the first ones to market, and they've had a lot of kind of lawsuits and things like that, but really the FDA has gone back and said that they're okay as well. So Pradaxa, Eliquis, and Xarelto and Eliquis. And Eliquis actually has probably the best data. So in old people with, you know, kind of at a higher risk of bleeding, I use Eliquis on them. So, and a lot of people are more in favor of that. But truthfully, I love Xarelto. This is, I mean, these two drugs, actually Xarelto is a game changer in my mind because basically those DVT-PEs now, they can go home the next day. I mean, there's no reason they need to bridge. There's no reason they need to do anything. You don't bridge with these. You just, well, you do bridge. You could give them, you know, a couple doses of Lovenox, but then you just give them Xarelto and they can go. So I mean, and I've also cardioverted people. I've started them on Xarelto and then cardioverted them within a few hours. So anyway, this is kind of the, you know, I spent a lot of time on this, but this is because you guys need to kind of know this stuff. And if somebody comes in on these drugs, you have to treat them as if they are on Coumadin. So, you know, they're at high risk for bleed. So there is a, so rate versus rhythm control. There was a study called the AFFIRM study, which occurred in 2002. And basically what they said was that rhythm and rate are rhythm control and rate control are the same. There was absolutely no difference, okay? So this was the primary outcome of that study, and basically p-value greater than 0.05 means that the patients did not do any better with rhythm or rate control. So they know, so you know, some people get obsessed with putting them back into sinus. That's not such a big deal. You know, we all just know that we want to kind of keep their rate under control. So this was the AFFIRM study. This was the, again, out at 5 years. Some significant, getting close to significance, but still not statistically significant. So no difference in death, disabling stroke, major bleed, or cardiac arrest. And then sinus rhythm was only maintained in only 63% of the rhythm control group. So, so there was no, so the take-home points on this, no survival advantage to rhythm control, Rhythm control patients were more likely to be hospitalized with adverse drug events. So that's why if we're using like a rhythm control agents like sotalol, propafenone, flecainide, those kinds of stuff, they could be hospitalized with adverse drug events. Both groups had similar stroke risk, 1% per year. The majority of strokes occurred when warfarin was stopped or the INR was subtherapeutic. Warfarin required long-term, even if sinus rhythm was restored. So this is another fallacy that I've seen around here, is that people believe that just because you're in sinus rhythm when you leave, that you don't need to be anticoagulated. That's really not the case. I mean, in post-op AFib, yes, but if you have a history of atrial fib, you need to be anticoagulated. Okay, this is, when you look at this study, the reason why people, even the people in rhythm control had strokes, and it was because they were taken off a Coumadin. So you have to be on something to prevent stroke. Let's see, torsades, bradycardic arrests were more common with rhythm control. Typical patient was a 69-year-old man without any symptoms. So maybe not as, not great with women and things like that. So it was kind of a, what I like to call a white guy study, middle-aged white guy study. Benefits of rhythm control. So why do you want to put someone in rhythm control? Mainly it's going to be because of relief of symptoms. If they're like, I know when I'm in atrial fib, I can't tolerate this, you're going to want to get them into rhythm. You get improved hemodynamics. The atrium gives somewhere around 20 to 25% of cardiac output. So if you get into, if you have a problem with, you know, heart failure, that kind of stuff, you got to try to get them into rhythm. Improved exercise tolerance, reduced risk of stroke, and avoidance of anticoagulants. It makes us feel better, but like I said, if they can do anticoagulants, I would go ahead and do that for them, even if they are in rhythm control. Some of the guidelines when it comes to atrial fib. Class 1 guidelines are guidelines that must be adhered to. If they aren't, you know, your quality could suffer. Treat patients undergoing cardiac surgery with an oral beta blocker to prevent post-op AFib. And patients who develop post-operative atrial fib achieve rate control by administration of AV nodal blocking agents. So cardiac surgery, beta blocker, post-op AFib, AV nodal blocking agents, which would be your beta blockers or your calcium channel blockers. So tips for achieving rate control. So things we can use, beta blocker. This is the one we all, I think everybody uses. I think everybody here who's in atrial fib is on a diltiazem drip at one point in their stay. So, I like to use beta blockers too. So in the unit, that's going to be Esmolol IV, low pressure IV. You know, other things we can use is low pressure PO. So calcium channel blockers, verapamil, diltiazem, again IV and PO. Digoxin. I've seen a lot of people use digoxin. Digoxin is nice because it doesn't affect the blood pressure, but not as a sole agent. And the thing is once they get up and start walking, dig is no longer that effective. So usually try to use that for, use it with a beta blocker or calcium channel blocker. Watch for renal failure. And then the other thing is, I don't really use a dose greater than 125 micrograms a day. I mean, I will IV load them, but other than that, I don't really see a reason to try to do that. We check dig levels to make sure that they're not toxic. That's really the only reason to do that. There's actually been nothing that shows that there's no such thing as a therapeutic kind of dig level. So you have to titrate to kind of effect. So even though even though it says, okay, yeah, you're in this level, but that's not really the case. You just, really the only reason we check the level is to make sure that you're not overdosed. Amiodarone in refractory cases when other approaches fail. only when other drugs are ineffective, and then we can do AV nodal ablation plus permanent pacemaker. This is Dr. Cooper's kind of realm. Oops. So rate control. These are best for people who are greater than 65, less symptomatic, and have hypertension. If they have recurrent atrial fib, rate control is a good reason. Previous antiarrhythmic drug failure, unlikely to maintain sinus rhythm due to enlarged left atrium. So those are people you just want to go for a rate control strategy. Treatment to achieve strict heart rate control, less than 80 versus less than 110, or defined as less than 110 during exercise, is not beneficial compared to achieving a resting heart rate of less than 110. So this is a key point. You know, everybody says, okay, well, you know, sinus tach or fast heart rate is greater than 100. In atrial fib, they did a study. The study basically did this. It said they did 110 versus less than 80. There was no benefit. So achieving 110 is actually probably the best thing. So that's where I would aim, especially in the hospital when you have all that other stuff going on. Let's see. Other guidelines, Class 2A administers sotalol or amiodarone prophylactically to patients at risk of developing postoperative atrial fib. This would be actually patients who get CT surgery, all of them are on amiodarone, so this may be to prophylax them from that. Restore sinus rhythm in patients who develop postop AFib by pharmacologic cardioversion with ibutylide or DC cardioversion as recommended for non-surgical patients. Let's see, this other stuff is administer antithrombotic medications in patients who develop post-op AFib as recommended by non-surgical patients. So, so that's that. Rhythm control. These are good for people who have a first episode of atrial fib. They got reversible causes. Symptomatic patient despite rate control. Patient unable to take anticoagulant due to falls, bleeding, or noncompliance. CHF, precipitated or worsened by atrial fib. And sometimes I use the young atrial fib patient to avoid chronic electrical and anatomic remodeling that occurs with atrial fib. So I like to use sotalol. I think it's a very good drug. It's underused here to kind of maintain people in rhythm control. Amiodarone has, especially in young people, has a really bad side effect. You guys know that. Thyroid, liver, lung problems that need to be constantly monitored. So it really becomes a really not so good. Now, I will use amiodarone in kind of older folks who are 75, 80, that kind of thing, because then they're, you know, something else will probably get them before the amiodarone will get them. Let's see. Okay. So achieving rhythm control, TEE cardioversion, they need to be anticoagulated, okay? There's no, this is another thing that I've seen here, variation in physician practice, and that is they absolutely 100% need to be anticoagulated. So that means heparin with a PTT that is therapeutic, Lovenox, at least a couple doses, or at least one dose, Eliquis or Xarelto, or Coumadin, okay? So the problem is, and then they need to be anticoagulated for at least a month to 3 months afterwards. I use 3 months. And the reason why is that you stun that ventricle, you stun the atrium, and that can cause a lot of clots to form. So you need to, I mean, there have been patients who they've asked me to or they've tried to get me to cardiovert without anticoagulation, and that is not really good practice. And you can actually cause a stroke like that. So that's not a good thing. TEE, they need a TEE if they have not been documented therapeutic or on a medication for at least 4 weeks. So like for example, for me, I don't cardiovert somebody. I'll cardiovert somebody if they've been on Coumadin with therapeutic INRs for the last 4 weeks, okay, or at least a month or two beforehand, and nothing's changed, or they've been on Eliquis or Xarelto. So that's usually that. Sotalol, like I said, I like that drug. Watch the QT interval. They've got to be loaded in the hospital. That's the only downside of that. Well, look, there you go. One of my persons converted. Amiodarone, again, LFTs, thyroid test, not good for long term. However, you can use dronedarone. Okay, that's the I forget what that one's called. But dronedarone.
Is that Multac?
Multac, that's right. So Multac, you can. Multac does not have the side effects. But it's a weaker agent. so it's less effective. So I kind of use this in young people who have used amiodarone to convert them, and then I just give them dronedarone. The other problem is that it's expensive. Again, flecainide, propafenone, monitor QRS and PR intervals. Ibutylide should not be given unless a EP doctor is around. That can throw people into ventricular fib. And then dofetilide, it requires special training to do that. Let's see. Antiarrhythmic expectations. So when you're giving them these drugs, the best thing would be complete suppression, but AFib recurrence is likely greater than 50% of patients, so they will fail their first drug. Recurrence per se is not a failure of therapy. The better expectation for even cardioversion or antiarrhythmics is the frequency of recurrence. That's a more realistic measure of efficacy, and it may vary from patient to patient. For example, this lady that we just talked about, she had a DC cardioversion a month ago, and then she came back, and she had atrial fib. So I would say, okay, yeah, that's probably a failure if they're coming back every month. But if I cardiovert them and I got them on a drug, and they're better, then I'll say, okay, well, then maybe we just don't, if I can cardivert them and they last for a year or two, that's actually pretty good. So, I mean, it's not all of a sudden you're going to cure it. It's not all of a sudden, it will likely recur. I mean, AFib begets AFib. So that's basically, once you have it, it's hard to shake. So. This is some of the guidelines. No or minimal heart disease. So if you're trying to maintain sinus rhythm, these are with their comorbidities. Basically, if they have no or minimal heart disease, you want to use dronedarone, flecainide, propafenone, sotalol first, and then you can use amiodarone or dofetilide, or then you can consider a catheter ablation. If they have hypertension and substantial LVH, you want to go ahead and use amiodarone. You could use sotalol, propafenone, or flecainide if they don't have that, and then use amiodarone. If they do have coronary disease, you want to use sotalol, dronedarone, or dofetilide, and then amiodarone. This is actually probably the biggest one, is heart failure. You want to make sure that you use amiodarone right off the bat. You don't want to use any of these other ones. Actually, coronary disease, I'm sorry. If you use flecainide, propafenone, flecainide or propafenone, actually, if you have coronary disease, that was shown to actually increase death. So there was a study called the CAS trial that they tried to use antiarrhythmics to suppress PVCs and all this other stuff with people with coronary disease, and it was an utter disaster. I mean, they killed people with it. So. Atrial fibrillation, so who are these people? These are people who have symptomatic paroxysmal or persistent atrial fib. They're intolerant of drug therapy. They have frequent ambient atrial activity. People who may have tachycardia-mediated cardiomyopathy. So basically, what this is, do you know what this is a picture of, anybody? Huh? Chicken? No? This is actually these are actually the pulmonary veins. This is where atrial fib comes from. These are what we try to isolate with atrial fib. So the procedure that Dr. Cooper does is he accesses the left atrium through a transeptal catheterization. Then he gets to the pulmonary veins, and then basically will burn around those veins, and that'll stop those. That's where they believe that all the atrial wavelets that are causing atrial fib are coming from. The results, they're difficult to interpret. Success, the single procedure is 60 to 80%, more like 60%. Multiple procedures, you can hit right around 80%, I would say. Poor patient is a person who's been 3 years persistent atrial fib with a significantly enlarged left atrium, because you're going to have a tough time mapping that. Best success is in a paroxysmal and healthy heart. So I actually have been sending these people a lot earlier now, especially if you're going to doom them to a lifetime of like Coumadin or some type of therapy. You're like, well, why not give them a try with the atrial fib ablation? So he does keep them on Coumadin for a bit, and then tries to demonstrate that they're not an atrial fib. The ultimate goal is rhythm control without toxic antiarrhythmics. So, I think a way to approach the atrial fib is basically what is the pathophysiology of the atrial fib? So what's causing it? What's the underlying cause? What else is going on with this patient? Are they septic? Are they, did they just have a trauma? You know that they're having catecholamine surges. There's all sorts of stuff that, and if they are having catecholamine surges, actually your best thing then is to use a beta blocker. What are the patient's symptoms? Are they short of breath? Are they having shortness of breath with exertion, chest pain? Will the patient benefit from cardioversion and sinus rhythm maintenance? Has anticoagulation been considered and implemented? This is another thing I see, people don't address this. So basically there are two things when it comes to atrial fib. Are they anticoagulated, and what is their rate? Okay, are they controlled, or are they not controlled? And then do they have some type of anticoagulation on board? Has the patient failed drug therapy? And then invasive strategy can be considered for pharmacologic failures. And I think that's all I got.